Welcome back. I hope you're enjoying these lectures about physical assessment. Last time we left off with vision screening. Specifically, we looked at checking pupillary response. We looked at being able to tell whether or not the patient had 20/20 vision with visual acuity testing and the Snellen chart. We also looked at color blindness, being able to test that with our Ishihara color plates. Today we're going to pick up on where we kind of left off with head and neck. And we're going to talk a little bit about the shape, symmetry of the face and the head. And we're going to examine the hair and describe that. So we kind of talked about, at first we looked at the general appearance of the individual. We said, do they look like their hygiene is good? Do they look clean? Do they look like their teeth are brushed? In this portion, I want you to kind of consider symmetry. And so what I mean by that is, let's say an individual was having a stroke. One of the signs that we might see would be facial drooping on one side. I'm going to talk about that in a little more detail a little bit later, but we always want to take a look at the individual and we want to see if they look like their face is symmetrical from one side to the other. Now, you know, some people can have a history of Bell's palsy where they have a little bit of a facial droop, maybe a little bit of a droop maybe on the corner of their mouth or something like that from a previous viral infection. And that is not a person that's having a stroke. So again, history is very important when you're assessing facial symmetry. We want to be able to look inside the mouth. We want to look to see if there are caries or cavities in the mouth, either that have been treated by a dentist or that have not been treated by a dentist. And we want to look at the mucosa and the gums. We want to see if they are moist and pink because that is considered normal. In this image here, you can see that this individual has quite a few dental caries or cavities that have actually not been treated by a dentist. And so this would require a referral to a dentist. You know, mouth care and good mouth hygiene is very important. We need to be teaching our patients. They should be brushing 3 times a day. Also, in long-term care, we need to be providing frequent mouth care for people who are unable to do that on their own. And so I want you to be aware of whether or not your patient has dentures, and if they do they have both upper and lower dentures, or do they just have one set? So here's an example of dental caries. So when we're looking in the mouth, assessing the mouth, we would be examining for redness or any kind of lesions, sores, patches. We want to look to see if their tonsils are enlarged, and a lot of times you'll hear someone say, was the uvula hanging in the midline? So we have the patient stick out their tongue and say, ah. Look with the tongue blade, and this is what we're looking for. So we can see here that the mucous membranes do appear moist. We can see that the uvula is hanging in the midline. And we can also identify that there's no enlargement of the tonsils. There's no redness, swelling, drainage going on in the back of the throat there. And so this is a pretty good example of what you would look at if you looked into a normal mouth. Let's move on. For head and neck, there is the ears. And so we want to look at the external ear. Does it appear well formed? Is it normal? We want to look at the nose. Is there discharge? If there is, what color is the discharge that's coming out of the nose? Is it clear? Is it yellow? Is it green? And we look for the actual different labeling. So here you can see the ear and labeling of all the parts of the ear. A couple of the parts that are important for us to know in particular is the pinna is actually considered the whole outer part of the ear, and you can see it identified here in this little blue triangle. And the lobule is another part. So this is a very important board type of a question that they like to ask. So to straighten the ear canal in the adult before observing with an otoscope, we want to pull the pinna back and up, okay? So in the adult, we want to pull the pinna, which is here, we want to pull it back and up to straighten out the ear canal so that we can then look inside of it with an otoscope. Okay, for a child, you actually pull the lobule down and back. Okay, so let's take a look at that. In this photo, we can see that the lobule is gently pulled down and back to visualize the canal in a child. This little person doesn't look very happy. Most little kids aren't super thrilled to go to the doctor and have the ear flashlight stuck inside their ear, which is why we let mom hold them and try to comfort them. We can get some buildup in that ear. We kind of, in layman's terms, refer to it as wax, or cerumen is the more medical term, and it can interfere with someone's hearing. Somebody might come to the doctor and say, you know, all of a sudden, after a period of time, my hearing in this one ear just got kind of like more and more dull, more and more like I couldn't quite hear as well. I can hear so much better out of this other ear. And when the doctor looks in there with the otoscope, the doctor can see that there is a large like ball of cerumen in there that needs to be pulled out with a special instrument that we see on the bottom, which is the correct way to do this. Sticking a Q-tip in there is not the correct way to do this. All the Q-tip's going to do is push the wax further in and can also damage the eardrum. So we want to discourage our patients from using Q-tips, sticking them in their ears because it's got a high risk for actually causing more damage than not. If you have a patient who needs to have their ears checked, want to send them to a doctor or a nurse practitioner, have them checked out appropriately, and get that earwax removed with the proper instrumentation. Okay? All right, so we are going to move on, and we are going to talk about the heart. So, assessment of the heart. There are a couple things we look at here. A lot of times in the charting, you will see them when they have identified that they've assessed the heart, they will write RRR. And what they mean by that is regular rate and regular rhythm. All right, so for regular rate and rhythm, first we know that a normal rate in an adult is about 60 to 100 beats per minute. And we know that a regular rhythm is lub-dub, 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 lub-dub. Okay, so that's a regular rate and rhythm. When we are listening, there are some landmarks that we look for. And so this is also a very classic kind board question. I have identified on this image here ribs. So you can see the ribs, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And then you can also identify this intercostal space, which is the space in between the ribs, all right? So it's important as a nurse to understand that we've got intercostal spaces, and we have something called a midclavicular line. And what that means is it's the center of our clavicle, the midclavicular line, and usually the fifth intercostal space is where we kind of start our landmarking for listening to heart sounds. So here we can see an image of both what it would look like on the chest, where we would be placing our stethoscope to listen to the aortic valve, the pulmonic, the tricuspid, and the mitral. You can see them labeled there. And then we can also kind of see on the other image where we can see the ribs, right? We can see the intercostal space, and we can see where we would be putting our stethoscope to listen at that midclavicular line in the fifth intercostal space. That is the mitral. We also refer to that as the apex. So listening at the apex of the heart. It's the place where we get the maximum volume. So we like to listen at the apex, which again is the fifth intercostal space at the midclavicular line. You can see that the aortic is in the second intercostal space, right? And that's to the opposite side of the sternum of where the heart is located, right? So the heart is located on the left side. We can see the pulmonic valve over the left second intercostal space, and that's going to be on the left side. We can see Erb's point, where S1 and S2 can be heard, although S1 and S2 should be able to hear them everywhere. But that is over the intercostal space number 3. And then we see the tricuspid valve over number 4 intercostal space. And then, of course, mitral, which we've already talked about. So let's talk about checking an apical heart rate. So when we check an apical heart rate, that means we're putting our stethoscope on the apex and we're listening either for 1 full minute, and we are documenting that number, should be between 60 and 100 in an adult, or we can listen for 30 seconds and we can multiply by 2. We have to remember that we're counting each lub-dub as 1. Okay, so we're listening to heart rate with our stethoscope at the apex, lub-dub 1, lub-dub 2, lub-dub 3. So every lub-dub is a count, all right? Get some practice doing it in lab. You'll be able to listen. You'll be able to count heart rates very easily after a few tries of practicing and listening, okay? So in the case of a murmur, remember we said we'd throw a couple abnormals in here and there. The direction of the blood flow is important when listening to heart sounds. A murmur can be heard anywhere along the axis. So for example, when we look at the landmarks for where to listen to heart sounds on the chest, we can see that when we're listening to the aortic valve, we want to place our stethoscope on the right side of the sternum at the second to third intercostal space, but we can see that that's not actually where the valve is, right? So if you look at this example here, you can see that where the aortic valve is marked and where we're listening, there's this axis between where the actual aortic valve is and where we're listening with our stethoscope, and along this axis, we might be able to hear an abnormal heart sound if there is one, okay? So we're gonna take a minute now, we're gonna talk about what a murmur is, right? So if we're listening to our heart, right now what we've done in this cartoon is that we've cut the heart in half. And we've opened it up and we're looking down into the ventricles, right? So what we're looking at here, and I'm going to just have you take a minute to kind of watch the animation, and we can see that lub-dub is happening. Lub-dub, 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 lub-dub. And you'll see that lub occurs during systole and dub occurs during diastole, when the heart is filling. We're looking at the AV valves opening, all right? So these are the valves that separate the atrium from the ventricles, and we can see them opening and closing during contraction, right? So in a healthy heart, the chordae, these are chordae tendineae and the valve leaflets actually prevent the valves from prolapsing during the contraction. The papillary muscles also give a nice chordae this extra pull during contraction so that they completely close in between. All right? So what happens in a murmur is that a heart attack can damage the papillary muscles and result in a dysfunction of the valve. All right? So if you look here, you can see that one of these valves is not closing completely. It's the left AV valve, also known as the mitral valve. And in mitral valve regurgitation, it's a type of heart valve disease in which the valve between the left and heart chambers does not close completely, allowing blood to leak backwards across the valve. It's the most common type of heart valve disease. And what you will hear when you're listening with your stethoscope is a murmur. Okay? So just take a second again to watch the animation and think about this. You're listening with your stethoscope and you're listening over the mitral valve and you're hearing a swooshing sound, and that is because there's some regurgitation occurring. That means that blood is regurgitating from the ventricle back up into the atrium. Okay? So I said we'd throw a couple of abnormals in here, and I know that this was a little bit more to bite off and chew, but we're going to study more of this. We're going to look at it in more detail. This is kind of just an introduction. Okay? So I think that that is all we are going to cover for this portion of physical assessment. I want you to go back in your textbook. I want you to read about physical assessment of the heart, read about apical pulse, look at the landmarks in your textbook, review these PowerPoint slides. Next time we're going to come back and we're going to talk about assessment of the lungs.